Once again grateful for the opportunity to be here. I am proud to present on behalf of my mentor, Professor Khairallah. Behcet uveitis is a manifestation of Behcet syndrome, which is one of the leading causes of uveitis along the old Silk Route, including the Middle East and North Africa. This is a sight-threatening condition. Early diagnosis and appropriate treatment are essential to prevent irreversible structural damage. So the diagnosis of Behcet syndrome is based on clinical findings. We don't have any laboratory tests to confirm the diagnosis of Behcet syndrome. There have been many criteria for the diagnosis of Behcet syndrome. The international criteria for Behcet syndrome have higher sensitivity than the international study group for Behcet disease to diagnose Behcet syndrome, but they have also less specificity. But both criteria just give a very vague description of the eye findings. So in 2021, the STAR working group developed criteria for the diagnosis of Behcet uveitis. We require findings that are compatible with Behcet uveitis and a diagnosis of Behcet disease using the international study group criteria. There is a better description of the ocular findings. We state the retinal vasculitis and the focal retinal infiltrates. However, many specific manifestations of Behcet uveitis still are missing. So there is a new algorithm for allowing the diagnosis of Behcet uveitis even in the absence of extraocular manifestations, because we may have isolated ocular Behcet syndrome in 15 to 20% of cases. So we should know which presentations are not compatible with Behcet syndrome. If you have anterior granulomatous uveitis, choroiditis, snowballs, or snow banging, it's not Behcet uveitis, even the patient has Behcet syndrome. What are the typical characteristics of Behcet uveitis? There are acute attacks of inflammation having a sudden onset, usually involving both eyes, and any type of anatomic type of uveitis may occur, and then the acute attack rapidly resolves. Manifestations are typically transient, but they recur, and between recurrences, if the patient is not treated, we have chronic residual subclinical inflammation. So when you have anterior chamber inflammation, it is usually associated with posterior chamber inflammation. It is non-granulomatous in type. The eye may be or not red, and we typically have a smooth layered and shifting hypopion. So when we change the position of the patient, the position of the hypopion changes, and this is a transient hypopion. And in contrast to HLA B27 anterior uveitis, we don't find any fibrinous reaction. We typically have severe diffuse vitritis, and as the vitritis is going to clear, we may see these pear-like inferior vitreous opacities one-third of the patients. They typically have this linear pattern along the edge of the vitreous base. And these lesions should not be mistaken for snowballs that are larger, that are chronic. The pill-like inferior vitreous opacities usually disappear in a couple of weeks. The retinal vasculitis is the hallmark of Behcet uveitis. It is typically occlusive, mainly involving the veins. So in the acute phase, we have this diffuse shedding of the veins, fluffy shedding, and when we have when we have the inactivity at the end stage of Behcet uveitis, the shedding is gliotic. These are typical findings in Behcet uveitis, Behcet vasculitis. We may have hemorrhagic vasculitis, frosted branch angiitis, or branch retinal vein occlusions. Fluorescein angiography is very important to show subclinical capillarites. So typically in Behcet uveitis, we have this diffuse retinal vascular leakage. This is a fern-like capillarites, typical fern-like capillarites. Fluorescein angiography also shows the extent, detects and shows the extent of retinal capillary non-perfusion. And we may have also optic disc new vessels that are not associated with retinal non-perfusion. These are inflammatory new vessels that doesn't need, these new vessels don't need any laser photocoagulation, and they regress under treatment. Optical coherence tomography allows to detect and monitor the macular edema as well as other macular changes. And OCT angiography have shown many macular microvascular changes, mainly areas of capillary non-perfusion, and the deep capillary plexus is more severely affected. Let's move to another clinical manifestation, key clinical manifestation of Behcet uveitis, the retinal infiltrates. These are superficial lesions that are variable in size, number, and location. And on OCT, we see this hyperreflectivity of the inner retinal layers without choroidal involvement. We saw during toxoplasmic retinochoroiditis that there is a localized choroidal thickening. In this case, the choroid is intact. And then these infiltrates will gradually regress, usually in a few days. They are transient, and they leave no visible scar. However, we have these residual retinal nerve fiber layer defects that we see on OCT. Just remember this aspect of vitreous exudate in front of the optic disc. This is very highly typical of Behcet uveitis. The main complications include macular edema as well as macular atrophy, neovascular complications, cataract, and the end-stage disease. So how do we manage Behcet uveitis? If you have isolated anterior uveitis, we prescribe azathioprine. If we have poor systemic prognostic factors, mainly young age, early onset, and male gender. If we have posterior segment involvement, it is unforgivable to treat the patient with systemic corticosteroids alone. So we prescribe at least azathioprine, and we have factors of bad prognosis. We have sight-threatening uveitis. Then we prescribe TNF inhibitors. So the anti-TNF therapy is prescribed is prescribed in severe cases of Behcet uveitis as the first-line treatment. It may be prescribed as second-line treatment in mid to moderate cases that are resistant to conventional treatment. And both treatments, infliximab and adalimumab, show similar efficacy and safety. However, the adalimumab is more easily given under administration in subcutaneous, and it is associated with a lower immunogenicity. If it doesn't work, we increase the doses, we shorten the intervals between injections, or switch to another anti-TNF inhibitors. And if TNF inhibitors fail, then we pass to other biologics, mainly tocilizumab. So the prognosis have completely changed thanks to a better recognition of the disease and to immunosuppressive therapy and biologics. And but sometimes some cases remain refractory to treatment. So Behcet uveitis is a sight-threatening condition. It may be the initial and sole presentation of Behcet syndrome, but early diagnosis is very important to prevent blindness. Thank you for your attention.